Thank you. I'm Rajesh. I'm a cardiologist at Stanford, and I'm a co-founder of HealthPals, a precision prevention company that is redefining preventive care. 80% of all heart attacks and strokes are preventable if you can actually institute the right preventive therapies at the right time. But we're failing at this. Half of our preventive medical decision-making is not evidence-based or guideline-based. But the guidelines are just part of the story. They're just the guardrails for real-world practice. Beyond the guidelines, no one actually knows what the best second-line diabetes drug is, what the best DOAC is for your individual AFib patients, and even if you knew how many patients were on the appropriate hypertension medication, is it actually the best medication for their age, gender, ethnicity, and even geography? Where are these real-world answers? Well, we usually don't know, or at least we didn't know, until now. Let me introduce Clint, short for Clinical Intelligence, HealthPals' precision prevention platform that maps patient data into evidence-based treatments. Clint automatically identifies every patient eligible for guideline-driven medical therapy in your clinic, in your health system, and in your country, internationally as well. It's a precision prevention engine that is encoding all of the medical guidelines for cardiometabolic disease and applies those guidelines to your patient data. It's customizable with other guideline societies, custom protocols, even future guidelines you want to model. It possesses vast amounts of longitudinal data, and it leverages machine learning to optimize treatments for different cohorts. Shown here is one patient example where the data from that patient's record has generated a 10-year risk score for heart disease, and you're seeing the proportional contribution of each changeable risk factor to the total risk, giving a prioritized list of what to do, in addition to other guideline treatments. This is summed with all the other patients in a clinic to produce an actionable, evidence-based population management tool that shows you all of the care gaps for medications and models the impact of closing those gaps on risk reduction for the population. We are doing this at scale. We are an innovation collaborator with the ACC and the Clinical Registry, and we have over 70 million patient life years of data, which we are now producing value for health systems, top 5 technology companies, and pharmaceutical companies. Let's talk about a use case. Let's say hypertension. A year and a half ago, the guidelines changed. It led to about 16 million more projected hypertension patients in the US. But who knows right now what percentage of those patients are actually on guideline-driven therapy? And what is the optimal dose and drug for those patients based on their demographics? So here's a demo of our platform. This is Pinnacle data. We're going to start with the diabetic population. You can choose the clinics, the comorbidities, the outputs in terms of the medications you want to model. Then you choose your guidance. What is the evidence? You choose the societies. You can toggle on and off different societies, custom protocols, and then generate a dashboard. That dashboard gives you a 10-year risk of ASCVD risk score before and after optimizing for changeable risk. And we model about a 17% absolute event rate reduction in these diabetic patients. On the right, you're seeing a geographic map, state by state, of care gaps or basically market opportunities for diabetic drugs. This can drill all the way down to the provider level. For safety, we're just showing it at the state level, and it can be modeled for any medication within the system. Now, if you look here, these are care gaps. Guideline-driven criteria to meet blood glucose regulation agents is terrible in the Pinnacle population. Over 50% of diabetics aren't on medications. That's probably why the A1Cs are so high. Now here's an area use curve where you can see the onset of SGLT2 inhibitors in 2014 starting to gain market share over the last 6 years and how they're actually eating into insulin and metformin usage at the population level. You can also do drug titration from one dose to another or from one drug to another in our system. For efficacy, let's go back to hypertension. You can see pre and post systolic blood pressures around the time of onset of first-line hypertension therapies, split up by different classes and combinations of meds. You can see that they were started at different times and different variances after being started. You can identify responder and non-responder populations and sub-cohorts of hypertensive patients, and you can generate a heat map on the right looking at various different features of patients against different types of hypertension medications, showing response or lack of response in those groups. So, there's a lot more going on behind the scenes. A key that opens a lock isn't the whole story. You have no guarantee that it's going to open the next lock. You have to understand all the tumblers that fell into place to make that patient better and why it may or may not work for the next patient. But machine learning unsupervised is not medically actionable. you're going to produce insights that aren't feasible because they're not constrained by the guidelines that are evidence-based, and they're not given a focused goal of a medical optimal state. That's where the Clint machine learning is very different from what's out there. It's constrained in the proper ways to make it feasible. We then take responder and non-responder populations. Using pair plot analysis, we can identify feature sets for those types of groups to apply in more detailed analysis. And of course, it's not just 2 features. This is a 27-dimensional analysis, and shown on the left is a dimensional reduction of 5 different non-responder groups to a specific hypertension medication. I can't say which because we're going to publish this, but if you expand that dimension, you can see 5 different cohorts with different feature sets, and you can use these signatures to apply to new patients to see if they're going to respond or not to a medication. So Clint is the next generation medical science discovery platform. It uses real-world data, medical evidence, customizable, and machine learning optimization. We're producing a suite of services that are providing value right now for pharmaceutical companies, technology companies, and single-payer systems. And on that note, we are proud to announce today that last week we signed an MOU with the state government of Manipur in India to roll out Clint across 2 million patients in their population to reduce cardiovascular risk, event rates, and overall spend. And we're approaching many other government systems in India, Australia, Singapore, the UK, and abroad. So thank you for your attention. I'll be happy to answer any questions.
All right, thanks so much. Let's start with Dr. Maddox this time.